mean weight, when really they mean medications that are used for diabetes as well as weight loss. So I wanted to start out today just by going through an overview of considerations of body weight, because there are certain diabetes meds that can cause weight gain, and there are other diabetes meds that can cause weight loss. The most quintessential medication that's going to cause weight gain is going to be insulin. Now, that said, it is very important if people have type 1 diabetes, obviously they are going to be on insulin for life. We also know that people who have really high A1Cs at diagnosis will also be on insulins for life. Similarly, the medications that are insulin, what are called secretagogues, they cause insulin to be secreted. These are your sulfonylureas, are also very likely to cause some weight gain. And then our TZDs, our thiazolidinediones, are also likely to cause some weight gain. So if you're working with one of your patients, you see that they are overweight and that they are on a TZD, a sulfonylurea, or insulin, it may bode well to have a conversation with their prescriber about whether or not these are the appropriate medications for them. Additionally, similar to insulin, sulfonylureas also have a very high risk of hypoglycemia. And we know that in our older population, hypoglycemia is a risk for falls. And as we know, as nurses and as care providers, falls in older adults can lead to very significant morbidity and actually lead to mortality as well. Women over the age of 65 who fall and break a hip are 50% likely to be dead within 2 years. So half of the women over age 65 that fall down are very highly at risk for both the morbidity and the mortality that can come along with a fall. So as you are working with your prescribers, and working with your patients, really, if they have hypoglycemia, unawareness, where they just don't realize that their blood sugar is low, just to remind ourselves, hyper and hypoglycemia look very similar as far as the symptoms. People can be shaky, they can be irritable, they can be very thirsty at the very high ends of hyperglycemia, but people can get dizzy. And so we really want to be sure that we're taking into account our fall prevention strategies, especially someone like Stephanie, who's a service coordinator at an elderly apartment home. Social workers, are you guys having problems accessing these medications? Because we have seen with the explosion of what are called the GLP-1 drugs, which is really what we're going to focus on today. Those GLP-1 drugs, because people without diabetes are using them for weight loss, there's been a shortage all over the place, and there are significant FDA regulations around the compounding of these medications. So Pam, I'm so sorry that you guys are having problems accessing these. Let's talk about potential alternatives, okay? If you can't get these GLP-1 drugs, which we're going to get into and do a deep dive into, you don't want to go with a TZD. You don't want to go with the sulfonylurea. You don't want to go to insulin unless you have to, because the injection burden. And for patients that may struggle with their dexterity, they may really struggle to administer those medications. For those of you that are social workers, please do recall that there are over-the-counter medications. And this Saturday, I'm going to be granted a diplomat in pharmacy law. And my research project has been into the impact of the Inflation Reduction Act on drug price negotiations. For the first time in US history, the American government is able to negotiate drug prices with certain select medications directly with manufacturers. In addition to those 10 drugs that were initially chosen, um, we also know that we have seen a lot of insulins come over the counter. And so, if you are someone who is struggling to access these higher dollar medications, or even if someone is struggling to afford their insulin glargine, aka Lantus, or maybe their Lispro, our old school insulins have gone over the counter. Insulin 7030, insulin NPH. They're a little bit more difficult to dose, but they are capped at $30 a month. So $1 a day for a patient to be able to get their diabetes under control if they cannot afford other medications. And that is in part because of the Affordable Care Act, which transformed into the Inflation Reduction Act under the Biden administration. It is primarily an agriculture and manufacturing bill, but buried in there is a lot of good information for patient care because we're now able to negotiate drug pricing. And depending on who wins the election tomorrow, we will either be going full force into the entire rollout of the Inflation Reduction Act, which is now a law, and there will be an additional 5 to 10 to 15 medications added every year into these drug price negotiations, which will save the American taxpayer estimated about $1.5 billion a year. Now, what we also need to look at is a lot of our meds that we really want are not on this list. The reason that they were chosen is because they're going to save Medicare beneficiaries. We know that out-of-pocket costs are going to be capped, and so we've got a lot of good stuff happening to help us help our patients afford their medications. But please remember that there are over-the-counter insulins that are capped. I think I said 30, it's $35 a month, but still roughly $1 a day. And so keep that in mind if people are struggling to access these medications. Another thing to keep in mind, we have our insulins, our TZDs, and our sulfonylureas that cause weight gain. There are old, very cheap medications that are weight neutral. Metformin, a great example of that. As long as your patient doesn't have any kind of liver dysfunction or have any history of rhabdomyolysis, which is the breakdown of muscle tissue that can cause, lactic acidosis, which lactic acidosis can be associated with our hyperglycemia. So that is a risk for metformin. But metformin, it's an old drug, it's dirt cheap, and it's weight neutral. We also have some other drugs that patients don't really like, our alpha glucosidase inhibitors. They work, but they work inside of the gut and cause the breakdown of different types of carbohydrates, which can lead to a lot of gastrointestinal symptoms. We know that modest weight loss is very beneficial for our patients with diabetes, and significant weight loss can actually resolve the disease entirely. So we want to look at our weight loss potential that we have, and the one that is everywhere in the news are our GLP-1 agonists. We also have our DPP-4 inhibitors, which are also weight neutral, and they also don't have this high risk of hypoglycemia that can be so dangerous in our older population. So let's talk about the GLP-1 agonists. These are drugs that not only can help improve our blood sugar, but also can lead to weight loss. Commonly on the news, what you're going to hear is GLP-1s. The official name is glucagon-like peptide 1. So if we remember back to kind of our basic physiology, we know that we have this balance between between glucagon and insulin. So in our brains, we have our genetics, our epigenetics, and our environment that affects our weight. But the brain can send signals all throughout the body. There are things like ghrelin, which help us to feel more hungry, GLP-1, which helps us to feel more satiated. There is also GIP, which can cause us to feel more satiated. We have CCK that makes our gut move more quickly. So the brain sends those signals to the gut. The brain also sends signals to our fat cells, which can cause us to have more weight gain. Things like leptin and adiponectin. We also have pro-inflammatory cytokines. And so if your patient is living just with this huge inflammatory burden, drinking soda all day or eating an unhealthy amount of fast food or just smoking, we know all kinds of things. Also, for everyone who is a social worker or maybe a home health nurse, I know during my days as a home health pharmacist, you don't learn as much about a patient as you can when you actually go into their home. Don't underestimate the role that mold toxicity in older homes, as well as lead toxicity, can cause when we are living in it, can cause weight gain. We have weight gain all the time associated with mold illness and heavy metal toxicity like lead. So when the brain sends these signals to our fat cells, it causes this excess accumulation of the most dangerous type of fat, which is our visceral fat. Remember, we've got a couple of different types of fat. Brown fat is the kind of fat that we want. That is the fat that insulates us. That's the fat that we are primarily born with. The reason that this fat is brown is because it is very densely populated with mitochondria. And those mitochondria, thinking back to 8th grade biology, powerhouse of the cell, it actually generates energy. Our white fat is an inflammatory type of fat. That is the fat that accumulates as excess body weight. Then there is beige fat, which is basically a stem cell for fat that can either go to this brown fat or this white fat. But visceral fat is the fat that accumulates around the midsection, leading to metabolic syndrome, syndrome X, whatever you want to call it. So patients that have this big pear shape around the middle are likely getting too many signals from their brain to have pro-inflammatory cytokines, leptin, adiponectin, which is causing this accumulation of our visceral fat, and is what is also leading to not just adipose tissue, but adiposeopathy. That's a really difficult word for me to say, but that is where the fat actually becomes toxic to us. Then what happens is our beta cells within our pancreas start to get overworked. They start to have dysfunction, and they can even start to die, which worsens the pathology of our diabetes. So excess adiposity and fat distribution has a major impact on the amount of insulin. So please, if you have patients that are normal walkie-talkie and are fairly healthy, that don't have diabetes, it may bode well to look at and see, do we have excess insulin? Because hyperinsulinemia, high levels of insulin, will predate any type of A1C elevation, any type of fasting glucose elevation, and will predate the diagnosis of diabetes sometimes by 5, 10, 15 years. So if you've got somebody in front of you that's got an extended life expectancy, be sure that we're looking further down towards the root causes, because if we can stop this accumulation of fat, we can potentially stop diabetes. And so primary clinical goals, if you're running an elderly apartment complex, just getting people moving. Getting people moving is so, so important. We know that every year diabetes guidelines come out in January, so we will have a new set of diabetes guidelines throughout the upcoming months. Nutrition education is very, very important. We also know that movement, even if it's chair yoga, even if it's just small amounts of movement, can not only improve our diabetic control, but we have 6 forms of exercise. And one that I think is so important for older adults is balance. And we've already talked about the morbidity that can come from falls associated with hypoglycemia. And exercise also helps to improve all of that balance that can reduce the risk of falls. Importantly, for all of our social workers that are on, only 13.4% of patients who have been diagnosed with diabetes in the past year receive any kind of educational visit. There are many different pharmacies around town. They're not paying me to say this, but I used to run a clinic out of FMS Pharmacy. They run free diabetes education programs. They have multiple locations around the city. And so look for pharmacies that are offering this type of education, as well as potentially getting some shoe fittings for our patients so that we just decrease those risks of falls. So nutrition, lifestyle, movement, getting people to understand that their medication burden. How many of you have patients that are like, I don't want to take that medication? I'm sure you all do at some point. Well, diabetes is, in a lot of ways, type 2 diabetes at least, is a lifestyle disease. And so if we can stop people from making bad choices, it's just one good choice at a time. If we can train our patients, how do we just make one good choice at a time? We can potentially offset the disease burden as well as the medication burden. Now, let's dig into these GLP-1 agonists and what are they and how do we recognize what one is and are they really worth all of the hype? So I mentioned that they can control blood sugar as well as lead to some weight loss. The other class of drugs that don't get as much press are our SGLT2 inhibitors. These are our sodium glucose co-transport inhibitors. So our first class of medications are our GLP-1 agonists. These are typically taken via a shot, either daily or weekly. Interesting story about how these drugs were discovered. The first of these drugs to market was exenatide. And the way that exenatide was discovered was scientists were looking at Gila monsters out in the Arizona and New Mexico desert. And they realized that these Gila monsters could eat a ton of food and then it just lasts them throughout a week or more. So they went in and tried to find out what was it that allowed these animals to stay satiated for this extended period of time. And what they found was that it was mediated by this GLP-1. And when we agonize GLP-1, when we turn GLP-1 on, it helps us to have a more even glycemic response, as well as allowing us to have this decrease in body weight. So since exenatide, the next one was extended release exenatide, so that instead of having to do shots twice daily, you now can do a weekly shot. Then came, the big guy on the block right now, semaglutide. One of the brand names is Ozempic. The other one is Rybelsus. We also have liraglutide, which is Victoza. And Lexazenatide, not as commonly used. That's under the brand name Adlixin. And then there is dulaglutide or Trulicity, which does get a lot of press. So all of these drugs mimic the action of the hormone GLP-1. That is a hormone that is secreted by your brain. It talks to your gut and it basically says, hey, you're getting full. What happens is when blood sugars start to rise after someone eats, these drugs help to stimulate the production of more insulin, but they do it in a way that does not lead to this overabundance of insulin that we see with the sulfonylureas that can really cause these tanks in blood sugar. Weight loss depends on which drug that you are using. Studies have found that these GLP-1 drugs can lead to a weight loss of somewhere between about 10.5 to 15 pounds. So not an insignificant amount of weight. Very important. A lot of our patients, especially older patients, tend to suffer from muscle wasting. Building of muscle in older adults can also offset the impact of aging and can really lead to longer lives. And because muscle is a sink for glucose, it also can help with our diabetic control. So if you're running an older center or you're helping your patients to understand what types of exercise, balance is one of them. I told you there were 6 types of exercise. We typically think of exercise as cardiovascular, right? Cardiovascular exercise gets a ton of press within the diabetes community. However, we really also want to be focusing on our weightlifting because that can help to offset the weight gain that can come from insulins or some of the older diabetes medications, and it may offset the need for some of these more expensive GLP-1 medications. So people who use semaglutide, the reason that Ozempic is getting all the press is because semaglutide in combination with lifestyle changes, this is really important. You can out eat and under exercise, under sleep, out stress any drug on the market. But when people make these lifestyle changes, weight loss can be up to about 34 pounds. So if your patient needs a significant amount of weight loss, this can be a very, very good drug for them. So our other class of medications, our SGLT2 inhibitors, are things like, these are all the drugs that end in flozin, right? So we saw in our last group of drugs, everything ends in utide or atide. These all end in flozin, canagliflozin or tugliflozin, dapagliflozin, and empagliflozin. And the brand names for those are Invokana, Jardiance, Farxiga, and Steglartro, excuse me. So those are the flozin drugs. Very importantly, I believe that everyone can have a hand in helping to understand the pathology of what is going on within our patients. These drugs work at the level of the kidney, and they work at the level of the kidney to help us to excrete more glucose in the urine. Great thing if you're wanting to bring down blood sugar. Very bad thing if you have an older patient who significantly struggles with urinary tract infections. So keep that in mind because you may be spinning your wheels as a social worker trying to find some specialty drug because you've got an antibiogram in your neighborhood where Cipro is not going to work and some of the more conventional agents aren't going to work for a urinary tract infection. And so if you see any of these flozin drugs, just remember that you're excreting more glucose in the urine, and one of the well-known side effects of these meds is going to be urinary tract infections. Lower blood sugars are not only helpful for controlling diabetes, okay? So let's talk about what are called pleiotropic effects. You may have heard this word as it relates to statin medications. GLP-1 drugs, we don't know why they cause weight loss. We don't. We do know that it helps to curb hunger. We also know that it can slow the movement of food out of the stomach into the small intestine. This makes our patients feel fuller, faster, and longer so that they eat less. The flip side of that coin is that it causes a lot of side effects that are GI related, nausea, vomiting, and diarrhea. And oh, Lord, we have so many of our diabetic patients who have gastroparesis where they can't empty their stomach into their small intestines. And you may see a patient that is on metoclopramide and semaglutide. Semaglutide, if you take that away, may be able to get rid of that metoclopramide because those two medicines are fighting each other. One is delaying gastric emptying and the other one is trying to speed it up. So again, just another great opportunity to give a pharmacist a call. If you've never worked with a pharmacist to do what is called a medication therapy management session, I very highly recommend those because that can help to identify some of these drug-drug interactions where, you as care providers, as nurses, and as social workers are either just spinning your wheels trying to figure out what is wrong with this patient, why can we not get things under control, or you may be trying to source very complex, very expensive medications when really we've just got two drugs that are fighting one another. We do have to use some caution. We do have to educate patients about our signs of hypoglycemia, which again, we all know the signs of hypoglycemia. We've all been hangry before, but just as a refresher, remember hypoglycemia is defined when a blood sugar drops below 70 for people with diabetes. However, in people without diabetes, we can tend to tolerate blood sugars down around 55. The first thing that's going to happen is you're just going to feel weak, tired, shaky, sweating, headache, hunger, nervousness, irritability, heart palpitations, another big one that we need to be aware of. Even though the GLP-1 drugs are less likely than insulin, less likely than our TZDs and our sulfonylureas to cause hypoglycemia, in people who have any type of atrial fibrillation or, God forbid, ventricular fibrillation, this heart palpitation and this regular and irregular heartbeat can be very dangerous. Hypoglycemia is very dangerous if not untreated. Remember your 15-15-15 rule. If you're working with someone who has hypoglycemia unawareness, 15 grams of carbs, wait 15 minutes, and then check again. And if your blood sugar has still not come back up above that 70 milligrams per deciliter threshold, then we want to redose with 15 more milligrams of carbs, which is about half of a Coca-Cola or half a glass of juice. I find that a lot of patients don't know what a 15 gram of carbs serving looks like, and people will end up doing more like 30 or 45 grams of carbs by drinking an entire cola or drinking an entire glass of juice. Bread also works. Just be sure that it has to have carbs. We can't be using keto breads. We can't be using anything that does not contain a high level of carbohydrates. If after that 15-15-15, the blood sugar still has not come up, that's kind of a do not pass go, do not collect $200, go and call your care provider because something else is going on. And me as a pharmacist, I always go to, is it a medication? Do we have too high a dose of a medication? Let's talk specifically about weight loss drugs in older people. We know that Ozempic is used in a lot of older people, but what are the benefits versus the side effects? We know that side effects burdens of nausea, vomiting, diarrhea, and constipation tend to be worse in individuals over 65. You may go, well, a little bit of nausea, a little bit of vomiting, a little bit of diarrhea. You guys, I have been researching a lot in the past few weeks about Parkinsonianism and Parkinson's disease. In general, constipation will predate Parkinson's disease by 5, 10, 15, 20 years. And a new onset constipation can lead to a huge medication burden. Senior adults often get put on stool softeners like Docusate or some of our stimulant laxatives like Senna. We also know that a lot of older adults are put on Miralax to handle the side effects of these medications. Now, Miralax is an interesting drug because it's PEG 3350. And according to science, it should be too big to cross the gut barrier and get into systemic circulation. Unfortunately, we see a lot of mental status changes in both children and older adults. And so mental status changes can be a huge burden on family, huge burden on care providers within nursing homes and long-term care facilities, and can necessitate the use of additional medications that we know to be dangerous in our older adult population, such as our atypical antipsychotics, as well as just leading to lots of mood disturbances and problems. So if new onset confusion, new onset mental status changes happen within a few weeks of starting Miralax, that may be your culprit. And so we know that older adults have a much higher risk of these GI effects. We also know that patients taking GLP-1s really need to be monitored for acute kidney injury because these medications can cause kidney problems as well as the SLGT2 inhibitors. We really need to look for acute kidney injury. And so as we're working on discharge plans or transfer plans, be sure that the kidneys are on the differential, especially in patients who have hypertension or have any kind of chronic kidney disease at baseline. Another major problem in older adults with the use of the GLP-1 agonists, loss of muscle mass. We all know that whenever you lose weight rapidly, one of the major problems is that you lose muscle mass. People naturally lose about 10% of their muscle mass between ages 60 and 70. And when older people lose weight quickly, the muscle mass can be lost very rapidly, putting them at risk for frailty, putting them at risk for falls, putting them at risk for fragility fractures, and ultimately worsening the pathology of the underlying diabetes because we don't have that sink for muscles. We also know that these medications can lead to outright sarcopenia. This is where people really lose a lot of their activities of daily living, which huge disease burden on care providers as well as oftentimes necessitating a patient going from an independent living situation into a more nursing home kind of situation. So if you have patients that are on this, emphasize how much that they need to be lifting weights alongside their GLP-1 agonist, because while they can cause 34 pounds of weight loss, if you're doing it too fast, you're going to lose much more muscle strength and muscle agility than you are gaining muscle mass, which is ultimately one of our biggest things that we can do to prevent aging. And in fact, if you're 25, 30, 40 years old, 45, listening to this call right now, especially women who are still menstruating, building your muscle mass now will extend your life in the future. It is never too late to start lifting weights. We know that people who are chronically obese also have severe complications. So we have things like heart disease, stroke, fatty liver disease that can lead to liver cancer. It also can lead to kidney disease, and as we have discussed, diabetes as well. So we really need to weigh the risks versus benefits, because it's not always all that it is cracked up to be. We need to think about weight in a different way. How are these medications? How are they used? They are injections. They are FDA approved not only for people with diabetes, but people who have a BMI of 30 or more. So that's an important threshold. If you as a social worker are spinning your wheels going like, I'm trying to get this med, I'm trying to get this med, if they don't have a BMI that necessitates it, maybe there is an alternative choice. People who have a BMI over 27 with at least one health-related condition, such as heart disease or sleep apnea, may also be candidates. So in the benefits category, people who take GLP-1s are going to feel fuller longer. They also have less cravings for fatty and sugary foods. Believe it or not, they also have fewer cravings for alcohol. So if you have somebody who is aging, alcohol, huge risk for falls, these medications may be beneficial for them. They may also be beneficial for people who have the sleep apnea and the fatty liver disease, as well as some emerging evidence in heart failure as well. But in addition, so that's our kind of like pro category. But in our con category, the loss of muscle mass is one thing, and that is the most important thing to take away. We also know that people over 60 who use these medications also have about 25% less bone mass. And 25% less bone mass is a bad thing because it puts us at risk for those fragility fractures. But it also will often necessitate the use of a bisphosphonate drug. So bisphosphonate drugs in combination with GLP-1s can be particularly risky because the bisphosphonate drugs can get into the esophagus and actually erode the esophagus. That's why we tell people after you take that medication to stay standing for at least 15 to 20 minutes, or at least sitting up. Well, we know that the way that the GLP-1 drugs work, one of the ways that they work is that they delay gastric emptying. So if you've got a med that can potentially eat through the lining of the esophagus or the lining of the stomach, and now you've got a med that's going to hold that medication inside of the stomach longer, that's a problem. Another big thing in people over 60 is nutrient deficiencies. Nutrient deficiencies, both macro and micronutrient deficiencies have been noted. Things like protein deficiencies, yes, but we also see, vitamin and mineral deficiencies, which can cause cognitive problems. They also can just cause failure to thrive, which is not what we want in our older patients. So I guess the bottom line, and I want to leave a few minutes for questions, you got to ask yourself, are you willing to stay on this medication for life? Because as soon as you stop taking the medication, the weight is likely to come back. Is it worth the potential risk, the kidney injuries that we've talked about, the hypoglycemia that we've talked about, the risk of falls that we've talked about, and even sometimes pancreatitis, which we always said in pharmacy school, don't mess with the pancreas because there's effectively nothing you can do. You also have to assess your patient's mental status. If they do not have hypoglycemia awareness, this may not be the medication for them. We also know starting at a low dose is going to decrease our risk of side effects. So if you are working to get these really high doses, just maybe talk to the prescriber about, is there a lower dose that might be better? Because you can always ramp up, but sometimes when you go too high, it's hard to ramp down afterwards. And we saw that no more clearly than with the opioid epidemic. And so we need to be sure that we have access to that ongoing care, not only to dose adjust as we need, but also to be sure that we are assessing delayed gastric emptying as well as our kidney function. Strength training, strength training, strength training. If I haven't said it enough times during this presentation, be sure that whatever type of exercise programs that you have in your facilities includes strength training. This is so important. And it doesn't have to be a lot of weight. I know I do a lot of Pilates. I never go above a 3-pound weight in those classes. But having someone hold a 3-pound weight for an extended period of time is enough to help build this muscle. You have to eat protein. Older adults need about 1 to 2.2 grams of, or 1 gram of protein for about every 2.2 pounds of body weight. And if any of you are, fast thinkers, you know that that's just 1 gram per kilogram is what we're looking at. But people have to be able to get protein in their diet. These medications are expensive. They are, and they will remain so until we have some generic alternatives. And until we have generic alternatives, I do think it is important for us to advocate for pharmacists being able to compound these medications. The good news is the Inflation Reduction Act does cover 3 of the meds that we've talked about today. So the cost reduction, sitagliptin, dapagliflozin, and empagliflozin, starting next year, will have a cost reduction somewhere between 38 and 79%. That is only for your Part D patients. Your D is in dog patients. And so we will see some cost reductions coming in next year. These medications were chosen because they are among the top Medicare expenditures, and they don't have a bona fide generic or biosimilar that can help patients to afford them. Because out of pocket, these medications can be upwards of $1,500 a month. So we will see some cost reductions coming through, but it may not be enough for every single patient to employ. So what questions can I answer for y'all in my last couple of minutes here?
One thing, Dr. Elmore, that was mentioned was the hope for notes or maybe follow-up slides or something. If you have those to present, I can send those out when I send the evaluations.
I'm more than happy to send out my notes about the drug pricing that I went through.
Yeah.
Believe it or not, y'all, that was pretty much like I've got some rough notes. I'll send you what I've got written down.
That'll work.
But it is just a rough outline. It is a blessing to be a pharmacist that you just kind of know medications. There also is a paper that I wrote a few years ago about canagliflozin. So if you'd like to read something specifically that's published in a journal about canagliflozin specifically, I also just I used my resources. AARP has some great articles about the use of GLP-1 agonists in older adults. I also love the Mayo Clinic's website for simple, easy to understand drug information for patients. And then the primary paper that I used was this one to refresh my knowledge. And so that was the main paper that I used. And I just got to give a shout out. Please, if you're working with older adults, keep this in your back pocket. I use this article all the time. Beers criteria. I think it's all of our jobs to prevent potentially dangerous medications from being used in our older patients, and Beers criteria will get you there.
And you have a question: what meds erode the esophagus?
The bisphosphonate medications. And so it's very important if you have a patient who cannot sit upright for at least 15 minutes, they do not need to be on a bisphosphonate medications. And those are medications that are used for osteoporosis and osteopenia.
All right. Well, we've taken your time. I know you've got another appointment.
I
Thank you so
appreciate
much.
y'all. Thank you, Sean, for the invitation. Always a joy to be here.
Thank you, Dr. Elmore. Have a great day. For those of you still with us, I'm going to read to you now and I'm posting in the chat room our evaluation link. Those of you who are watching online on YouTube will need to listen to this. It is https://www.surveymonkey.com/lowercase r/all uppercase letters, B as in boy, P as in Paul, Q, G as in girl, N as in Nancy, 3S. And our password for the day is diabetes, and I'm posting it now in the chat room. So again, for those of you online watching on YouTube, https://www.surveymonkey.com/lowercase r/B, P, Q, G, N, 3S. Thank you all for being here. I hope you have a great week. Join us again on Monday, November 18th, when we will have a presentation about Medicaid waiver by Shamara Jones, who works for the Greater Regional Planning Commission and awards Medicaid waiver. So I'm hoping this will be a great presentation for you to join us. Thank you for being here today. Have a great week, and we'll see you soon.